Hello, everyone. Welcome to today's episode with Functionally Enlightened. We have a wonderful guest today. I've learned so much from Dr. Towfigh, so I'm going to read to you a bio and give you some information of who she is, what she does, and the amazing work that she's doing in the research world and in the advocacy for her patients. Dr. Shirin Towfigh is a general surgeon with specialty in hernia surgery. She is board certified by the American Board of Surgery and the European Board of Surgery. She has been treating patients with hernia-related issues for over 20 years, with special interest in treating women's hernias, occult inguinal hernias, and chronic pain related to prior hernia operations. She's the founder and the president of the Beverly Hills Hernia Center in California, where she treats most of her patients. She's internationally recognized for her innovations in hernia surgery and has held multiple leadership positions in national and international surgical societies. She is widely published with over 200 articles, chapters, and a book named The Sage's Manual of Groin Pain. She hosts the weekly podcast Hernia Talk Live, where she and her invited guests answer your hernia-related questions. You can find her and follow her on social media under the moniker @HerniaDoc. So thank you so much, Dr. Towfigh, for taking some time out to speak with us and our audience today.
Thank you for asking me. It's been a pleasure.
So I've learned of your work over, I guess 4 years ago when I underwent my own hernia repair surgery that was a fiasco. And I tried to locate some of the top doctors in the United States and internationally, and you were one of the names that was at the forefront. So I am really excited to dive into this subject with you. And first, so we can start off, can you give us a little bit more about your type of work, what got you into the field, and the types of cases that you've been taking on recently?
Sure. A lot of people ask me why I'm a hernia surgeon, because that's not a well-defined specialty practice. You know, people understand plastic surgery, general surgery, head and neck surgery. Hernia surgery is kind of a subspecialty within general surgery that has not yet been well-defined. So my very first patient and my very first job was a mesh infection patient. And it was at a county hospital, and she was just being bounced around between the different services. It's a very resident-run facility, and so the residents, of course, didn't know how to handle it. And I had already learned about mesh infections, and biologic mesh had just come out. This was year 2002, so the first biologic mesh came around 2000. So I'd been exposed to that in my residency, not a lot, but enough to kind of at least know. So I took her on as a patient, and then after that, people were like, "Oh, well, she's okay, like handling these complicated abdominal wall things." And so I started getting all the referrals in the county system for the abdominal wall hernias. And then in 2008, when I changed jobs, I said to my new job, I said, "Listen, I just want to do hernias. You know, the typical general surgery practice, a lot of gallbladder surgery, appendicitis, you know, taking a lot of call." I said, "I don't want to do any of that anymore. I just want to just focus on hernias." And they said, "That's great. Sounds good." And that's how it all started. And I learned from my chairman in my first job. He was he was like, "Just take a disease process and do a deep dive. That will make you the best surgeon instead of being a jack of all trades." And so that's what I did. I just took hernia surgery. So I'm deep dive into that. And, you know, it's now my 100% of my practice. And I try and pick topics to learn and research about that are not well understood or underrepresented. And mesh implant illness is one of those.
And that's the type of clients that actually I serve, people who've undergone surgical trauma and have experienced toxicity overload, or specifically in this case, mesh implant illness. And there's some who've experienced breast implant illness, which is in similar naming. So Asia syndrome is what it's referred to, or foreign body reaction. Can you talk about how people approach you when this is their main concern?
Yeah, these are all diseases I never learned in medical school. I think they still don't teach it. And I had to learn based on listening to patients and understanding it. So more and more we are advancing surgical technique, and that involves using a lot of medical devices. And some of those devices are implanted in you permanently. It can be sutures, it can be clips, and staples, but it can also be meshes, screws, breast implants, and so on. And so we're now learning that it matters what you're putting inside a patient, right? B, not every patient will respond the same to the same implant. Some people do great, other people, their whole life is destroyed. And C, it's really important that surgeons believe patients when they come up with complaints after, let's say, a surgery that's not very typical. My belief is always believe the patient. They don't want to be sick. They don't want to go to the emergency room. They just want to have a normal life. And when they come to you with something that doesn't make sense, don't just knock it off, oh, you're crazy, or that doesn't happen. At least be open to the idea of the fact that we don't know what we don't know, and we don't know what we'll learn in the future. Stuff that I learn now, I didn't know 20 years ago. So that's kind of the humbleness you have to have in medicine about the unknown and the challenges that patients present to you with the unknown.
And that's very much appreciated. I'm sure that all of your patients appreciate your understanding, your willingness to investigate beyond what can be seen in a typical blood panel, or
Yeah.
Even the antibodies for autoimmune conditions. Sometimes they're not flagged, but you know there's some deviation from their symptomology, first off, and there might be some indications that they're heading towards an autoimmune condition, or maybe just excessive inflammation. So how do you go about potentially screening your clients before they come into surgery for the possibility of, things like mesh implant illness?
Yeah, one thing I tell them is we are still in the learning stages of things. So don't expect me to know exactly what to do and everything that's right to do. We're still in the learning stages. So that kind of sets the tone a little bit, because I know a lot about hernia surgery, but I'm learning about mesh implant illness. We're actually the first to ever actually coin that term, mesh implant illness. And believe it or not, it was very difficult to get that paper published, because surgeons were like, this doesn't exist, or, you don't have enough patients. But there aren't thousands of patients that I can study. This is how, education starts. So I'm very grateful to the editors of the Journal of Abdominal Wall Surgery to A, publish our paper, and B, make it free for everyone to be able to go through it and read it. So I'm very grateful to that. So I go through a certain number of questions, and we're coming up with an actual questionnaire, a mesh implant illness questionnaire, where we're really focusing on your risk of having an inflammatory or autoimmune response to things. So number one is, do you actually have an autoimmune or inflammatory disorder? Do you have Crohn's disease, rheumatoid arthritis, things like that? POTS, MCAS, which you've talked about before on your show, right? Mast cell activation syndrome, even people with bacterial overgrowth. Those are all somewhat interactive and linked, even maybe even collagen disorders. So that's how I start. Now, if it's a male, mid-aged and above, not anorexically thin, with no history of any allergies, no asthma or environmental allergies, never gets rashes, is otherwise healthy, that's a patient I would consider very low risk to react to an implant. Not zero risk, but pretty much low risk. Because I have had men that are totally normal that end up with a mesh implant illness. But if it's a female, usually younger age, usually super thin, with a known autoimmune disorder or sensitivity and allergies to a lot of medications, clothing, environmental stuff, then I take pause and I say, okay, are there alternatives in treating this patient without mesh, without an implant? And I try and err on that side. The thing with surgeons is we want to be these perfect surgeons. So if I fix your hernia, I don't want you to come back to me and say, I have a hernia again. Right? That would be considered a failure. That said, every single hernia surgery has a risk greater than zero of recurring. It just happens for various reasons. And we're taught to kind of minimize that risk, right? With no matter what. And that's where all these different meshes came about. My thought and practice has changed, where I explain to the patient, are you agreeable to accept a higher risk of recurrence, let's say, but not have an implant in you, understanding that it's still a good result, you know? Let's say, oh, a 0.5% or 1% recurrence will be 5%. It's still a 95% success rate. However, if you do recur, then we're going to fall into a situation where we have to consider an implant or mesh, and there are other options. There are various options nowadays that there weren't 20 years ago. But that's the way I approach it. I try and do a little bit of a risk assessment to see how do I kind of navigate the different options I offer this patient for hernia repair.
So going to the original surgery, there's a lot of questions have been presented to me that it's definitely out of my wheelhouse. I am not a medical doctor or a surgeon, but there were some questions presented to me regarding sutures and how to prevent adhesions.
Yeah.
What's your line of work when it comes to that? If somebody has had multiple abdominal surgeries and you know that it's probably going to be difficult to get access in there, how would you work with them to try to minimize that risk?
So all surgery causes some trauma to the tissues. Trauma causes trauma, right? So if you've had, let's say, a gash on your face, you'll see like there'll be a scar there. And that's basically an adhesion. And inside, there will also be adhesions or scarring. So all surgery will cause adhesions. The question is, are those adhesions relevant? You know, some people do fine and their entire life. Other people have pain from the adhesion, intestinal obstructions, etc. There are anti-adhesive products on the market that you can use as a surgeon to reduce scarring, but you have to be very cautious because you need scarring to heal, right? So if I never scarred down my, let's say, a facial gash, if I don't scar that down, that wound will never heal, be open wound. That's a horrible outcome. You want just enough scar to make it heal, but not enough to cause, like, let's say, a very dense scar or adhesions or bowel obstruction, etc. So there's a balance there. But we do have some, specifically 2 different anti-adhesive barriers that can be used during surgery, and then there's another one coming in the market, hopefully soon, which I'm really looking forward to. So that's one. And then in terms of sutures, there's permanent sutures and there's absorbable sutures. And depending on the type of surgery, it may demand using permanent sutures. Let's say vascular surgery, permanent sutures. You don't want those sutures to open up because then you'll blow out your aorta or something, or your heart surgery, right? So those are permanent sutures. And then some of the permanent suture, and then for hernia surgery, we either choose permanent sutures or sutures that last like, you know, almost a year, 8 months or so, to allow for your body to kick in during that healing time. Some people react to those sutures. That's very uncommon, I would say. Of all the implants, people don't really react to sutures as much as, let's say, mesh. So mesh is like 100 yards of suture, whereas suture would be like 6 inches of suture or 4 inches of suture. So that's kind of the difference. There is some thought that it's a volume issue, or a density issue. So someone who may react to mesh, which is a lot of suture that's weaved into a mesh, will do just fine with a little bit of suture. Whereas some people, I've removed their mesh, but I'm like, I need to do a suture repair. And I use suture, and then they react to the suture. And then they had to take out the suture. Those are very complicated, but uncommon.
With that being said, a couple of things come to mind. The first is what you were discussing, like the surface area of the mesh versus the surface area of the suture. So
Yeah.
my theory is, again, related to biofilms that are developing on this material. So it's designed to create this inflammatory response, like you mentioned, for the healing process. And so I'd imagine with permanent mesh that it's going to permanently have some sort of reaction there. But the issue happens when it becomes chronic and the inflammation starts impacting systemically the body. So I'm thinking with this, if a biofilm is forming on the mesh or on the sutures in those very limited cases, is there is there any studies right now currently on allowing or treating those biofilms with biofilm breakers and not impacting, not removing the mesh, but allowing these bacterial colonies to kind of break apart and, be excreted through phase 2 and phase 3?
So I'll give you kind of what I understand about biofilms. The discussion about biofilms was mostly not in the Western medicine world. It came about a lot, and therefore, my impression is that most medical doctors either don't know about biofilms or don't believe it's a thing. Because if you culture the same wound or the mesh, the cultures will show no bacteria usually. So that's an issue. However, with time, we're learning more about it. For example, I just listened to a podcast about breast implants, and they were talking, these are great, very intelligent plastic surgeons, medical doctors, so Western medicine, where they're talking about the thought is that the reason why certain breast implants cause capsules and or contracture is because of biofilm. And so they're doing a lot of, they're putting betadine and all these antiseptic methods of implanting, changing gloves and so on, implanting breast implants to reduce the risk of that. In the general surgery world, there's not as much discussion about that. I do change gloves every time I touch mesh, just to make sure there's no bacteria between when I start the surgery and when it's time to put in the mesh to contaminate, so start anew. That is not considered standard practice, although a lot of people do that. The orthopedic surgeons do that a lot. They everything's super sterile, and they even wear, like, for hip implants, they wear these like astronaut suits so that even their like skin and hair and all the breathing doesn't affect the implants. And they're in special rooms where the air only flows one way and so on. So for orthopedic implant, they understand that let's say hip implant infection is devastating complication, and they do change gloves a lot. So that hasn't happened as much in the general surgery world, but we are talking about it, I would say. So I'm not familiar with any biofilm medication or treatments at all. So if you want to teach me, I'll learn more about it, because I don't really know how much research is being done. I know there's a lot of research being done on biofilm, but how much of that has trickled into the clinical practice?
Right. It's definitely an interest of mine, having experienced it myself. The
Yes.
type of mesh that was used in me was Phase-X, and it was Phase-X ST, so I'm assuming that's the Sepra technology or that barrier you were talking about.
Yes, and one of the anti-adhesion barriers on the market, Seprafilm, yes.
Yes. So in your practice, is that a type of mesh that you would use? And can you give us some idea as to when you would use that rather than the polypropylene, like the standard mesh?
So there's I would say two categories of mesh, the permanent and the absorbable. And Phase-X falls in the absorbable mesh. In general, absorbable mesh is not considered standard for most hernias. So if you want to use absorbable mesh, it's because there's a reason why you don't want to have permanent mesh in there, or the patient is not a candidate for permanent mesh. Let's say there's an infection in the area or it's not a clean area, so you want to err on something that won't get infected, which are the absorbable meshes. And then in that absorbable mesh category, there's biologic meshes and synthetic meshes. So Phase-X is a synthetic version, and let's say Alloderm, Stratus, MTF, Flex HD, those are in the kind of biologic arm. And then there are these hybrids where you can get a little bit of biologic, a little bit permanent, and so on. So again, these are things we didn't have 20 years ago, but we're slowly improving. My personal bent about Phase-X is it's a very synthetic, highly processed inflammatory mesh. So even though technically it's absorbable, it acts like a synthetic mesh because it is a synthetic mesh. It acts like a permanent mesh because the way mesh works is you put it in the patient, it causes a massive inflammatory reaction. and that encourages everything to stick to it. That's what you want. You want the mesh to stick to the tissue so it doesn't fall apart, so your hernia doesn't recur. But you also want that inflammation to die down after weeks to months. And in patients with mesh implant illness or chronic pain after implant, that inflammation never goes away. And I feel that's the problem with Phasix, is that it does cause an inflammatory reaction. That's how, because it's synthetic. And so if you ask the company, they'll show you a lot of data that shows it's not inflammatory at all. But I've seen it in my patients. So there's a disparity there. If you look at data not by the company, by other people, it shows it's one of the most inflammatory biologics on the market. So I do not use Phasix for that reason. That said, I was involved in the original clinical trial to see if there's any benefit to this mesh, and I specifically used it. I thought it would be beneficial in people that need surgery often, right? So they have a hernia, but they have, let's say, Crohn's disease or some small bowel tumor, or cancer, where you may have to go back in multiple times, take out cancer multiple times, and so on. You don't want to have to go through pure mesh. That complicates the situation. So I was implanting it in those patients, and they did well, but there are other things in the market. So I tend not to use Phasix.
And still, some of the surgeons I've spoken to, they don't make that association with inflammatory response or the fact that Phasix is synthetic. They claim that it's biologic. And when I went into
it's by definition, it is a synthetic absorbable.
Yes. So I believe it's polyester. It's the material that
it's P4. It's fancy.
P4HB, I think.
P4HB, yeah. It's I think technically it is a petroleum-based absorbable.
Yeah.
So it's very complicated chemical name.
Right.
It's one of the uses was to use it around breast implants to kind of make the shape of the breast implant kind of form better, especially in revisional surgery or if someone didn't have good muscles. And I called one of the plastic surgeons. I'm like, do you know you're implanting something highly inflammatory and it's still a mesh, and you got all these women with breast implants, you're adding that. And of course, like, not a big deal. We've had no issues, but it's a rare problem. So if one surgeon never sees it, they may continue their practice. But, I don't consider it appropriate because I see all the complications. So in my practice, I see a lot of patients, relatively speaking, whereas someone who has a general practice may not see it ever, or the patient may never go to them because they'll discount it. You know what I mean?
Mm-hmm.
So.
Yeah. And it goes by a different name, I believe. Is it Galaflex or something? So
Galaflex.
Yeah.
Well, yes, Galaflex, but it's complicated. But they basically, same company made it and sold it to two different companies to sell it.
Mm-hmm.
And then Becton Dickinson just bought the company itself. So it's all one company now.
Okay. Interesting. So it just brought that up to patients who don't ever look at their medical records really when they're trying to get to the bottom of why they've been feeling ill, and you know, implants are probably not at the forefront now. Now that with all the studies, it's becoming more research, more in the public space. But again, if you don't look at your medical records, you don't even know what was implanted in the particular surgeries.
Right.
With respect to surgery itself, there's been another concept floating around about, the impacts of general anesthesia causing, substantial chronic conditions over time. Not even you go into surgery and maybe you're led to believe that it may be a week or so, the anesthesia should be fully eliminated from the body. What are your thoughts around this?
Good question. So there's a lot of general anesthesia going around. So we have not seen this as a major problem. In other words, the percentage number is actually very low. Now that said, it's a lot of people undergoing general anesthesia every year. We do know in patients that are older or having cardiac surgery, or that already have like some type of dementia and so on, general anesthesia may make it worse. And we think it may be related to two things. One is the amount of blood flow to the brain during the surgery, and or like little clots in the brain that happen that someone normal would not notice, but someone with already demented may get worse. And also the medications themselves. Theoretically, the medication that is injected into the bloodstream should be out of your bloodstream either immediately or over several weeks, depending on which medication's used. So if a patient has general anesthesia, they're going to feel kind of fatigued and groggy and not so cool, potentially for a couple weeks. And I get that in some of my patients. I therefore err on not using general anesthesia as much as possible. It's very easy to do a lot of good surgery without using general anesthesia. But I don't know that we know enough about it. I would recommend for you, since you're an academic and have this great environmental engineering background, I'll share with you the link. There's a society out of Israel with the original Dr. Schoenfeld of the Asia syndrome. Are you part of that group?
I am not part of that, so I appreciate
It's
it.
it's a weekly international webinar where they talk about everything related to Asia syndrome. Autoimmune or Asia's acronym ASIA, autoimmune or autoinflammatory syndrome induced by adjuvants. Some people also call it Schoenfeld syndrome, and Dr. Yehuva Schoenfeld actually hosts us. He's the most amazing guy, so funny and intelligent and inclusive. And it's late at night for me. It's like 10 or 11 p.m. at night for West Coast. So maybe even worse for you to log in. But people talk about COVID vaccine, COVID virus. I was the first person to introduce mesh to that group. But they talk about anesthesia, mosquito bites. I mean, there's so much that can be introduced into your, like Lyme disease, so much that can be introduced to your body that then sparks this reaction. And then doctors are like scratching their head, and it's all that Asia syndrome type situation.
So I have an idea again about the amount of stressors on the body. You get mesh implant, and that is definitely a stressor. That's a foreign body. But all of the other chemicals that you're exposed to during the surgery, plus everything leading up to surgery, our world is a kind of a dangerous place if you're not cautious about what you eat, what you drink, where you breathe, your air. Like we can't really control the air.
You
But at
can't.
least in your house, you can try to minimize the toxicity. But that's a different story there. What I think is that, as if clients know that they have, and patients in your case, that they have a predisposition to allergies, or they've struggled with other types of implants, even things as small as, the breast clips that they implant for biopsy, for instance.
Biopsies.
That was something that I had gotten prior to my surgery, and it took weeks to heal, but I never thought anything about that. So things like that, maybe if a patient is going in for any type of implant, even mesh implant, that might be something to consider. And so we do know that mesh might be the only option for some patients. And can you talk a little bit about that dividing line?
Yeah, that's a very difficult situation. And I have one patient that right now that significant mesh implant illness. And we've tried multiple different meshes in her, right? So it wasn't just one. We tried polypropylene, we tried polyester, we tried, every time the mesh was taken out, her hernias recurred. And every time the mesh was put back in, she had a severe reaction. And she has a collagen deficiency disorder. So a non-mesh repair is never going to work on her. So that's a very difficult situation. I would say that the best way to either do well by having your mesh removed or do well without a mesh to start with is to reduce all your risk for everything else that can cause hernias. Chronic cough, treat that. If you're a smoker or use weed that causes coughing, do edibles, stop your nicotine, make sure you're of normal or just kind of lower normal weight, because that's another risk of pushing on hernias. Exercise and get excellent muscles. If you have an enlarged prostate and you're strained to urinate, fix that prostate because that straining causes hernias. If you tend to err on constipation, treat that like you would diabetes. Every day, take whatever you have to do so you never strain. Those are all risk factors for hernias that are modifiable. And then choose a surgeon who understands physics. I feel like so many surgeons don't understand physics and they do the wrong thing. Understands physics, understands that a tight repair is not a good repair. A tight repair will actually tear. If I give you a tight shirt, you're going to tear through it. But a good repair with multiple layers where each layer supports the tension off the other layer. That's why Shouldice works very well it's 4 layers. Each layer takes the tension off the next layer. And then it's very judicious as to, you still need sutures, what sutures are going to be used. And some sutures break more often than others. Some are more inflammatory, some are stretched more. So there are options with sutures, and so on. But every patient's a little bit different. Every hernia is a little bit different. People come with different risk factors. Maybe their lifestyle, they're a construction worker, they work at the baggage claims in the airport. Those are jobs that are a little bit higher risk. If you truly have that problem, like this patient I told you about, she's like, when I mow the lawn, I was like, mow the lawn? Don't you have a gardener? She's like, that's you LA folk that have gardeners. We don't have gardeners. We do our own mowing the lawn and gardening. And I'm like, oh, well, maybe consider not doing it because you're like a hernia machine,
Yeah.
hernia factory. So, yeah, you need to really go through it very detailed and knock off all the potential risk factors. And that will be in preparation for your surgery. So you have a good non-mesh surgery with the right sutures to reduce your risk of a bad outcome.
I love that you dive into that holistic outlook, and looking at the lifestyle of the person to design what's going to be the best practice for them. In my experience, I received maybe 3 or 4 consultations before getting the surgery. Unfortunately, I didn't know about hernia specialists. So they were still with general surgeons in combination with plastic surgeons. And so some plastic surgeons aren't aware of repairs, especially a full abdominal reconstruction that can be done without mesh. So I know that that's an option for certain types of hernias. Can you explain which ones can be covered by that type of procedure?
Yeah, so we think of hernias really in 2 categories. One is the abdominal wall, the other one's in the groin, pelvic. So the groin ones, there's good data from like 300 years ago, 200 years ago, where you can do tissue repair, right? Shouldice is the most common, but there's McVeigh, Bassini, also there are all these different techniques, Marcy. So those are all tissue-based repairs that are appropriate for almost every patient. Even for a femoral hernia, which is the gold standard to use mesh, you can use a tissue repair. The outcomes are considered worse, higher recurrence rate, actually a good amount of chronic pain, especially if you make it too tight, or in someone that with a higher risk of surgery, which is why Shouldice doesn't even do it if you're obese, to like, come back, we're not going to operate on you, because they understand the higher risk of recurrence and chronic pain. So for the groin, a lot of really good tissue-based repairs are available. For the abdominal wall, if it's a small hernia less than 1 centimeter, pretty much tissue repair is considered valid and appropriate, do not need mesh. If it's a hernia 2 centimeters or larger, you have to err on using mesh. And then between 1 and 2 centimeters, if you have a low risk, I tend not to use mesh. If you're a high risk patient, let's say you're morbidly obese, I would use mesh. So that's the algorithm that I follow. What we're trying to figure out is, of the people that really should get mesh from a pure evidence-based scenario, how many of those can we pluck out and push in the non-mesh category? So one thing that was very exciting that we presented at the European Hernia Society, and everyone really thought was really unique, and the paper should be published soon, is in patients that have a diastasis. You had a diastasis, right? Rectus diastasis, where you have a stretching of the abdominal muscles away from each other and therefore a thinned fascia or tissue in between. And people that have that and have a hernia, we know that you can get a tummy tuck and I'm using the term tummy tuck loosely. It's really a plication or inversion of all the muscles, tightening of the abdominal wall, and include the hernia with it with good results. Then we said, okay, that's established. I mean, most people who get tummy tucks have a little belly button hernia or something that's integrated into their tummy tuck and no one even knew about it. Then we said, okay, then there's this other subcategory, incisional hernias. So that means you had a surgery, you had an incision, let's say you had colon surgery or trauma. That incision now has a hernia. We call those incisional hernias. According to the landmark study from the Netherlands, you really need to put mesh in those patients. Otherwise, there's a 50% or higher risk of hernia. If you make the incision, you get a hernia from that, then you try and close it again, just like they did it the first time. It's going to fail at least half the time. So they said use mesh for all the patients. There was actually on Twitter yesterday, there was a poll. Who was a surgeon that put the poll up? Incisional hernia, how many of you would put mesh in 100% of patients, right? And the question was like, yes, all the time. No, depends on the size of the hernia. Because if you have a 1 centimeter incisional hernia, I wouldn't put mesh in that, you know. I'm just here to look at the answers. And almost everyone said, 100% of the time, 100% of the answers were number 2, which is depends on the size. But then over time, it became 50-50. So there's a lot of surgeons out there that still believe 100% of the time, if you have an incisional hernia, you must put mesh in because that's what the studies show. So we started working with a plastic surgeon. We said, okay, you have patients, or I have patients with an incisional hernia and this diastasis. So you're a candidate for tummy tuck, but you're also a candidate for hernia repair with mesh because it's incisional hernia repair. Can we bring those two together and do the tummy tuck as your incisional hernia? So you're using your own muscle as your quote mesh. And there aren't that many people that fall into that category, right? But still, we did our studies up to, I think, the 4 centimeter hernia. They did great. I think 4 or 5 centimeter hernia. They did great. No mesh. We have 6 years of study right now. They're doing great. So you just have to think outside the box a little bit and not say everyone needs mesh. You don't want to hurt people and not use mesh at all, but there are little categories we're starting to chip at where we can argue that non-mesh repair is better. And I like to say, I've been talking about this since 2008. Finally, and I think 2009 or 2010, around there, I was hosting something called the Great Hernia Debate, and we talked about mesh only. And I made some comment like, my grandchildren are going to be like saying, wait, hold on, what? You were putting plastic in people? In their body? You thought that was a good idea? Like, what the,
Yes.
And we're there now. We're there now. So now, this was like revolutionary back then, but now the societies are inviting people to talk about mesh. Mesh implant illness is considered something that multiple institutions are now talking about. It's no longer, quackery to talk about it, right? And books are asking us to write chapters on it. So there's, it's infiltrating the education of doctors slowly.
That brings me to a concept that I've been studying a lot on microplastics and nanoplastics. I've studied this in the environment so much. And so I'm thinking, especially with the absorbable mesh, like it's converting, but there's still these nanoparticles now in the body that can also develop biofilm around it. And it's traveling, systemically through your blood. And these nanoparticles, if you think about it in terms of size, it could be billions more times surface area than the particle itself, like the actual mesh. So a lot more exposure, a lot more area for bacterial growth. And that's
Okay.
just one idea that I'm really diving into the research of this. And of course, clinically, it's not something that's easily approached.
So
So
I have a question for you. One of the things that we notice is the countries that are most interested in this are US, UK, and Australia. They have the most vocal patient population.
mm,
And yet, China, India, which have the highest population in the world, we're not seeing a lot of people with mesh implant illness and these things in those worlds. Now, they also don't use as much mesh. That is true. But there is some thought that but I have friends in Germany, Turkey, Poland, Portugal. They're like, we're not seeing this in our world.
mm,
But I did give a talk, where was I last year? Brazil? Was it Brazil? Yeah, Brazil. And I had surgeons from Argentina show up and say, we specifically came because you were at this meeting talking about this problem because I have this one patient. So there is a sentiment that it's more prominent in English-speaking countries.
mm.
Do you think we're just using too many water bottles and being exposed in our natural daily life? Or what's your thought about why we're seeing an uptick? Because during my residency, there was none of this stuff,
Mhm.
but we're seeing it more.
Yeah, definitely the amount of plastics we use and we indicate that things are recyclable, but how exactly are they being recycled? There are studies showing what the proper type of recycling is for different labels. Like if you look at the bottom of
Mhm.
your bottles, but the fact that all of this is still ending up in our waste stream, maybe 70% of population isn't even recycling.
Yeah.
It's in our waste stream, it's in our landfills. The landfills, they have certain leachate ponds to collect the runoff of this. There has to be liquid that's pulled away from the solid waste.
Mm-hmm.
And eventually that can either percolate into the groundwater or is discharged to some other water body that's not supposed to be technically connected to our drinking water supplies. But with the amount of waste that we generate, like there's very slim chance of capturing all of that discharge. So that's one thing. And then again, with our personal care products having so many of these toxic chemicals, the phthalates and the parabens in our products, and all of that going into our water supply, eventually, not to take it into environmental engineering, but we think of bioaccumulation through
No,
the
that's important. I think your take on it is so important because we don't have that experience or that knowledge base. Do you think that it's an exposure issue? So for example, my body's now developing antibodies against these exposures, and then you put an implant in me and it just goes
yeah.
crazy?
That's my opinion of it. And definitely the same with if you're taking pharmaceuticals for an extended amount of time that it wasn't designed for, then that's gonna build in the body over time. So it's just the concentration. Everyone has their bucket where, there's a different amount that you can fill it before it starts overflowing. And so
Nice.
people who already are full of toxins are gonna probably react more quickly to these types of implants.
Yeah.
So if there was a way that we can integrate that into clinical studies and see, what the statistics say on it, that would be an amazing thing.
Would you have to get like blood samples from, let's say, go to like some county fair and get everyone's blood samples or something, or
Yeah,
what do we even look for?
right. And you'd have to define the study very specifically, just like with the others, like what population are you going to serve? Is it people
Yeah.
who've already experienced implant or general good health? It's a study that I'd love to kick off, but I guess I need to have a certain amount of interest in it and the right line of experts to participate. Yeah.
Yeah, so we have a survey, which I hope people that watch this podcast, if they have any type of implant illness, not just mesh, can maybe fill out because, like I said, we're still in the learning curve. So that's a survey that's ongoing, it's open, it's live. They can just answer some questions and kind of tell us what the symptoms are. because I'm learning the symptoms because the same patient tells me the same thing. And the rash is my favorite one because you can't fake a rash. You know, you can say you have hair loss, but do you really have hair loss? I mean, you can say that you got, brain fog or problems concentrating, but can't really test that very well.
Right.
A rash you can't fake, right? So that's my favorite. When I see that, I'm like, oh wow, that's a great one. Very diagnostic
Mm-hmm.
in the right clinical setting. But I just wish there were a blood test. There's no blood test. When you do blood testing for normal things, it's normal.
Mm-hmm. So the functional labs, we run a lot of functional labs, and there's more markers like gut dysbiosis and pathogenic growth, things like that that can be associated with it. But again, there's no one-to-one correlation. So it's more like
Yeah.
if there was a baseline that we could
Yeah.
go from before and after implant, then that could give us more of a story. In terms of, well, that survey first that you mentioned, I'm sure you have it linked to your website and your social media platforms.
Yes, it's pinned on every single, if you go to Instagram, it's pinned
Yes.
as a top one. Yeah.
Okay. I also have it linked on my Instagram link tree. It's one of the top links there. So I encourage everyone to participate if you've experienced implant illness or you suspected implant illness yourself, or you have a family or loved one,
Yeah.
that anyone can participate in this, right?
Yeah, it's free. We're not asking any information. Someone said, that there's a lot of there's the whole legal bent to these things.
Yes.
And some lawyer told their client, don't fill it out because it's going to I don't know, somehow affect their legal case or something. I don't know. But it's completely anonymous. I don't know who you are. I don't even know if you fill it out. We don't ask any information besides all your symptoms. And we do ask your sex. So it's doesn't go anywhere. I don't ask for emails. It's complete. You can do it from any computer, laptop, doesn't matter. Completely anonymous. It just only helps us learn. So I hope there's no kind of misinformation out there that somehow this information can either be linked or it can be found in any way.
And I'm sure people can use a public computer if they want
Yeah.
to be connected with their IP address or something. Even some, people have.
Use our friend's iPhone.
That's true. So with that being said, we'll make sure to include a link to that survey.
Thank you.
If you share that paper, that publication, where you discuss mesh implant illness and you talk about the statistics between, how they presented before and after removal.
Yeah.
We'd love to include that in the show notes too for people's research. And I know we're getting close to the hour, so to respect your time, there's one other question that I would like for you to address if you can.
Sure.
Well, two actually. If someone does have mesh implant illness, you've worked with them, you've isolated that it's not autoimmune, it's not, I guess it's not going to always be 100% mesh implant illness, but in your professional opinion and evaluation of a client or a patient, how would you go about assisting them or directing them if the removal is not possible? Or would you say that removal would always be a possibility?
Removal is possible with 100% of patients. Always possible.
And that's something they're told the opposite. Like even in my case, they told me maybe 10 surgeons said removal was not possible. And then
your situation was relatively straightforward.
And then they give you the I call it the scare tactic, where they say you're going to recur in a year. Not really knowing.
I mean, that's fine. Deal with it in a year. At least we'll know if removal makes you better.
Right.
And then at 1 year, we have more information. And at that point, we can figure out if you can get a tissue repair. You can start losing weight or work on your constipation or whatever risk factors there may be to get you a better candidate for tissue repair. There's hybrid meshes, low inflammatory biologic meshes that we can potentially consider. There's a lot of options. They're not ideal. The surgeons want an ideal surgery for you. Some people can't get the ideal surgery. It's just the way it is. Until one day we have better tools, but for now, we can't go for perfect. We just have to get one where your life is not destroyed by the surgery.
Yeah, and there's the defining point. Is it more important to try to have it removed and see if your quality of life resumes, or at least partially returns and you regain some functionality, or if you're going to stay doing the same thing and, opt for lifestyle changes as much as possible. But in my case, definitely it was the former. I had to have the removal. I know how drastic my quality of life changed from the day before to actually the day after. Like, it was immediate for me. And that's not necessarily the case for most people. I would imagine it takes a little bit more time. Again, that toxin buildup over time that presents as an autoimmune or an inflammatory response that's ongoing.
Yeah.
So that being said, I have met quite a few people in my journey that are looking for a very knowledgeable surgeon, and I point them to you.
Thank
But can
you.
you share where our audience can reach out to you, or if you take virtual appointments, or how you can see people in your practice?
I'm licensed to practice in California. So if you're in California, then you have the option of coming in to see me or doing a virtual, kind of like we're doing here. Outside of California, it gets tricky. I can't practice medicine outside of California. So what I can do is, if you want to send me your information as what we call an online consult, it could be anywhere around the world. You can just contact my office. We have a whole protocol for it. You can send me your information. I can kind of review it and give you my opinion, understanding that I haven't examined you. You're not really my patient. But at least I can guide you. I can say, there's a doctor, like you had Dr. Eunice. You can see Dr. Eunice near you. You can share kind of my write-up. It's more of an email communication. I'll give you like a complete write-up. It's actually kind of nice because you get everything written down and emailing back and forth. So that's the other option to do. And hopefully we can provide access elsewhere in the world, so I can see patients that are in need of my expertise. But that's the best I can do right now, is this online consultation. So my nurse, you'll contact her through all of our emails or phone calls. She will gather your CDs of your CAT scans, email, ultrasounds, MRIs, any blood tests you have, any surgeries you had before. I'll review them and kind of give you a guide as to which direction I think you should go. Is this mesh implant illness possibility, and so on. Oh, one more thing. We're coming out with something called the Hernia Score. Did you hear about the Hernia Score?
Yes, can you
These
tell us
are
a little bit about it?
a lot of people that contact me with the online consultation don't even know if they have a hernia. So we're coming out with, if you go to herniascore.com, that will help determine if your pain is from a hernia in the groin. So that we're kind of excited about that little project too.
Yeah, give you a lot more guidance to start your journey, especially if it's chronic pain that you're dealing with.
Yes, but if you go on any of my social media or my website, beverlyhillsherniacenter.com, you can just contact us through that, and we'll follow up with you.
Perfect. We'll share that link and also your Instagram handles. And do you have any other social media that you use, or you have Hernia Talk for sure?
Yeah, we have our weekly Hernia Talk live. It's similar to yours. It's live on Facebook Live and Zoom, and then you can listen to all of it either on my YouTube channel, which, again, at Hernia Doc, or as a podcast, Hernia Talk Live podcast. It's kind of cool. We've been doing it for 3 years now.
Yes, I've enjoyed learning from you. Definitely a good source of information. I recommend always to take Dr. Towfigh up on this not a virtual, what is it? Like this
online consultation.
Online consultation, because not too many surgeons will actually review the CDs, your scans, your MRI, and Dr. Towfigh, she's an expert at it. Like, she can
I'll look at it with a fine-tooth comb.
So take her up on that option, because your quality of life really doesn't need to be as limited as it could have been with
It's so true. So many people say, I have this pain. I'm like, but you don't have to live with pain. There's treatment for almost every hernia-related problem.
Yeah, absolutely.
And by almost, I mean like over 95% of them is treatable.
Yes, those statistics are much better than what we're led to believe if we just practice. So again, Dr. Towfigh, I appreciate your time. I know that our audience gathered a lot of valuable information from you.
I appreciate you, and I'm so glad that you're doing this. I just love not only the personal connection that you're sharing, but also your environmental engineering. That's so unique, and it's very relevant. So thank you.
Thank you. And thank you to our audience for listening. We'll see you on the next one. Take care.
Appreciate it.